Hello, and thank you for joining us today for Opioid Use and Misuse, Trends and Community Impact. I'm Andy King with the Corporation for National and Community Service in Washington, D.C. I'll be your host for today's session. Also joining us are Bethany and Joanne, our partners at Education Northwest, who've helped to prepare today's webinar, and they'll be managing the WebEx technology for us. You'll see all of us in the chat and Q&A to help address questions that you may have during the session. Before we dive in, let's take a look at the goals for this session. By the time we finish, we'd like you to be able to gain an understanding of opioids and the history and trends leading to the current crisis in the United States. We also hope you'll be able to identify some of the structural factors that correlate with opioid use and misuse, that you'll be able to identify some current interventions and supports that can be applied to combat the crisis. And finally, we'd like you to reflect on session content to see how it may be relevant or could be applied to the work that you're doing as a VISTA. I'm happy to introduce our main speaker today. Dr. John McElveen is an Operations and Policy Analyst with the Oregon Health Authority in their Health Systems Division, and he serves as the State Opioid Treatment Authority for the state of Oregon. John is a licensed mental health counselor. He has served several years of direct clinical experience in treating patients with alcohol and drug disorders, and he was the former Director of Assessment and Education, as well as the Associate Director of Research at a large substance abuse treatment facility. Dr. McElveen's experience is vast in this topic, and we're happy to have him join us and present this webinar. Now let me turn it over to John McElveen.
Thank you so much for the warm welcome, Andy, and welcome everyone, and thanks for inviting me. Again, I won't spend a lot of time going back over our learning objectives. Andy covered that well. But again, I think just to kind of recap a little bit, I'd like to start off with a little bit better of an understanding, so we're speaking the same language, as we say, is what are opioids. Again, there's so much stuff in the media and so many different things that are kind of, frankly, bombarding us right around this issue. And I think, as with any issue, when we try to figure out something, and obviously it's complicated, and we'll get into that as the webinar goes through. But in a complicated subject like this, I think it's important to understand the facts and also kind of the history. And when I say that, kind of how we got here, and maybe hopefully dispel some myths, and maybe just overall just kind of increase your knowledge of the subject, and figure out what has worked and what hasn't. And again, that's key to helping us chart the course for the future. So we'll start out with the slide that you're probably seeing titled Opioids 101. So I want to talk a little bit about some definitions and descriptions of what we mean, again, so that we're all on the same page. When we say opioids, it's a class of drugs, right? Opioids include all opiates, which are naturally occurring or naturally based opiates, pain, analgesic medication, as well as synthetic or man-made. When I say man-made, essentially what I'm saying is that they're created in a laboratory, and that their chemical composition mimics, essentially, more or less, the natural occurring opioid product. So when we talk about naturally occurring opioids, we're talking about things like heroin, codeine, morphine. These are things that are directly derived from the poppy plant. The synthetics are things such as fentanyl, oxycodone, hydrocodone, and methadone as well. And so these are the synthetic, or again, the man-made opioids that I mentioned before. Opioids are primarily used to treat physical pain, right? That's why we call them analgesics. Analgesia meaning pain relief, and an analgesic meaning a medication to relieve pain. And opioids fit in that class. They're a very powerful, one of the most powerful of those drugs. Opioids have an interesting mechanism in the way that they act on the body and the brain. Opioids are attracted to when they're consumed, and no matter how, and I know it's not a pharmacology class, so I don't want to get too deeply into it. When your body consumes opioids, they make their way to the brain, and they attach to what are called the MU receptors. So those are your brain's what it does is it manipulates your endorphins and your endogenous system. So they boost feelings of pleasure. Now we have, and I'll talk about this in a minute when we talk about the history, our endogenous system naturally produces opioids, helps us emotionally regulate, and opioids take that over and they basically control or block the pain, but provide the user with a sense of euphoria and analgesia. Misuse and prolonged use can clearly lead to dependence and addiction, and is particularly dangerous because it does have long-term brain changes. I'll mention something about that as we go forward. The potential for dependence, I think these are just some takeaways, is incredibly high. Opioids are highly tolerant and dependent-inducing, right? So when I say that, and again, I understand it's like pharmacology and we're not purely doing addiction 101, but your body has a need for them. When those are taken away, an individual can go into a withdrawal state, which is a physical manifestation of having those drugs removed. One particularly insidious thing about opioids is the incredibly high rate of tolerance and dependence that people develop who abuse them. For example, a great way to look at it in terms of juxtaposing it against another drug of abuse is alcohol. Many Americans, 85%, drink alcohol occasionally, but only around 10 to 12% will develop a serious physical dependence. With opioids, it's completely different due to that really targeted nature, and that's what I want to emphasize, that targeted point that opioids go to in your brain to create that chain of euphoria and analgesia I spoke about. A very high number of people, anywhere from 50 to 70%, there's lots of different numbers that float around that, but they're fairly consistent in that window, will become physically dependent on opioids, and that's going to result in withdrawal symptomology when people restrict their opioid use, or when it is restricted for them, I should say. Again, a little bit of history. I mentioned before the media, and we tend to get kind of almost, as I said, bombarded. I use that word because it does feel like that sometimes, right? You pick up a paper on the internet, and it's all about opioids. And opioids are very complicated drugs in terms of drugs of abuse. You know, the World Health Organization says that you need 3 medicines to be a modern medical system. If you don't have one of these, you're not technically a modern medical system, and that is antibiotics, so penicillin, right, fight infection, NSAIDs, commonly known as, we know them as ibuprofen, right, they're anti-inflammatories, and morphine, which, again, as I mentioned before, is a naturally occurring opioid. So when you think about it, opioids are in a class to themselves, not just in a pharmacological sense, but in terms of a drug of abuse and in terms of their impact on society. Not to say that we don't have concerns with other drug use and alcohol, which is, of course, still a drug, but opioids present kind of a very unique situation in terms of addressing consequences of use and misuse. And they're not new, and it's not new. Opioid use is not new in the United States, as you see on your slide. There was a significant number of individuals, Americans, that were opioid dependent. Opioids have been around for around 5,000 years. It was originally thought of that they were first discovered, the historical consensus is, I should say, in modern-day Iraq. People discovered the poppy plant, and it was used even then. It's very, very common at the turn of the 19th, 20th century for people to be using and be dependent on opioids. It was given for a million different types of maladies, simple pains, aches, headaches, and the like. And remember, opioid, we have a sense where we think of now drugs as all being illegal. Opioids were not illegal then. They were easily available. But literally, I know it sounds crazy to some people, but in mail-order catalogs. But this slide basically, and again, we could talk about this for a long time, but I just wanted to spend another minute mentioning some of the key points here. What are some of the key things to know? The 1914 Harrison Act, okay? This is really a turning point, originally designed to regulate commerce. What it did was essentially tax opioids coming into the United States because of course, remember I mentioned it was neither illegal nor legal technically. It was just totally unregulated. So obviously the federal government's not making any money off that, and there's no regulation. What the Harrison Act essentially did morphed from a trade act to essentially something that impacted both practice and the way we see addiction today. you could no longer, or a prescriber, a provider, could no longer prescribe opioids to somebody for a non-recognized medical condition. Addiction at the time was not. So, for instance, maintaining someone's dependence, to keep them from having withdrawal symptoms was essentially illegal. And physicians and providers were, in fact, arrested for it in some cases. So, again, prohibition, de facto, of opioids essentially created this criminalization of addiction and resulted in a huge increase in illegal drug importation in pretty staggering amounts. So essentially, it was a violation of law to prescribe opioids to a, quote, opioid addict. That, in fact, did not change until 2000, which is farther down on the slide, with the Data 2000 Act, which allowed people to prescribe buprenorphine in office settings. So again, it wasn't seen, opioid addiction wasn't seen as a medical condition, wasn't seen as a disease, it was seen as a weakness of will. And so that impacts how it was treated. As you get on the slide, you can see the examples of the narcotic farms, abstinence-based treatment, kind of work in terms of putting folks into hard labor, different things, outdoors, and the idea that the fresh air and the hard work would be curative to the individual's condition, which we know now, I think, and most of us see addiction as a treatable medical condition. They had very poor long-term outcomes, nearly 100% relapse rates. I would add that these were some of the pioneers in this work, and we did learn a lot from them. We learned about what worked and what didn't, and that helped feed our knowledge, our perceptions, and the way that we came around to more evidence-based treatments, in fact, moving forward. Beginning in the 1970s, the government was looking at drug abuse on a much broader scale. Drug abuse treatment in general. This was the time where opiate treatment programs, methadone clinics were authorized to function fully as fully licensed state and federally licensed and certified facilities to treat opioid addiction back then. Just as a note about nomenclature, we use a lot of different words with this. We used to call any drug abuse either abuse or dependence. And that nomenclature has changed to now what we call use disorders. So alcohol use disorder, you'll probably hear me say opioid use disorder and the like. That's just something to note. Lots of different things happened in the 1970s around, I mentioned the rise of methadone treatment. Remember I mentioned the endogenous system and how opioids work and manipulate your system to create euphoria and analgesia. Well, the link between that and the endogenous system, which I talked about before, was something we didn't really even know until the 1970s. Methadone treatment began actually in the 50s and 60s during a heroin crisis in New York City. Individuals working with these patients found, in summary, they just simply didn't get better. They had no improvements. And that's when somebody, Dr. Niswander and Dr. Dole from the Rockefeller Institute, among other pretty esteemed facilities and medical institutions, realized that this was a brain condition, possibly. It wasn't simply a matter of willpower. So again, I mentioned before the Drug Abuse Treatment Act of 2000. What that did was expanded opioid treatment, office-based opioid treatment options. 85 years, people, as I mentioned from the Harrison Act, folks couldn't get medication-assisted treatment or medications to treat their addictive disorder. When I say medications, talk about that a little bit more in a few minutes. But medications, just as anybody suffering from any chronic condition would have access to medications, hypertension, asthma, diabetes, or the like. It wasn't until 2000 that legally a provider could treat somebody with a replacement therapy for this condition. So again, moving forward, you're probably looking at the slide that talks about prescription opioid sales. That's in treatment from 1999 to 2000. Very quickly, I just want to note something here. One of the big drivers of our current opioid crisis was most certainly the overprescribing of the 90s and the 2000s. So that's one of the things that I know we're most bombarded with right now, in that what's the link between, say, overprescribing, people being, quote, cut off from their opioids, and that link between heroin usage. So that's a complicated issue, and we'll talk about that more in a few minutes. But this slide really is just meant to show you very tangibly how, as sales went up, unfortunately, deaths per 100,000 people went up, but also treatment admissions for 10,000 people. And that's, you can see it's almost, it becomes an exponential growth, 400% increase within a decade. And I don't think we've ever seen that with any other drug of abuse. That's that extreme of an increase, and it's certainly absolutely driven by that. Now, a lot of other factors involved too, increasing availability of things like heroin. I'll talk a little bit about the link between OUD, remember that's my acronym, I know. We use acronyms a lot in this business. So the opioid use disorder, the rise of the prevalence of that, really kind of outstrips anything we've ever seen from any other rise in drugs or drug usage trends in the United States. But to go forward, talk a little bit about the link between heroin and prescription opioids. One thing, the 2000s saw obviously a very stark increase in heroin usage in the United States, and Americans' opioid usage was at very, very high levels. 2009, about 180,000 new users, about 1 million people at the time were estimated to be addicted to opioids. But just 3 years later, the estimate was somewhere around 460,000, and around 2 million or so people technically addicted to prescription opioids. So again, that's that huge, you remember my last slide where I showed that steep, almost exponential growth. This is kind of another look at that, but they're very consistent, right, unfortunately. A couple different things when we talk about opioid use and some characteristics, trends, so you get an idea. Some of you may or may not know, but the U.S. and Canada, it's still pretty close to this. We have had the drops in prescribing. I'll talk about that in the context of another program we're going to mention as a success. We've had drops in prescribing, but in 2015, the United States and Canada, throughout the early 2010s, and even before, the U.S. and Canada consumed about 95% of the opioids in the world. That's an enormous amount. I can't think offhand, I know I have it written down somewhere, what our two countries' percentage of population in terms of the rest of the world is, but I think everybody here knows that it's not 95%. And it kind of begs the question for the layperson, well, why are we using that many opioids? And I'll throw out something here just to get you thinking about it. Opioids are really good for physical pain, and at first they work for emotional pain. Not so well as a long-term solution, but I want you to kind of think about that when you think about why the heck do Americans use so many opioids? So in 2013, I mentioned opioid use disorder, and let me mention a few more notes on that before we move on to the next slide. This edition of the Diagnostic and Statistical Manual of Mental Disorders, it's kind of the, we'd call it the SUD and mental health disorder Bible, so to speak. It's kind of the book that we go back to, especially if you're working as a clinician, and many of you are in different capacities. But diagnostic for manual for SUD, substance use disorders, as well as mental health conditions. So, and this is really important to put in context, working with people impacted by this, working in systems. Remember I mentioned we used to have abuse, an abuse category and a dependence category. We've now moved away from that, and OUD or SUD, substance use disorders in general, have become a spectrum type model. So again, that whole other conversation about the pros and cons of that. A lot of people like it, a lot of people don't. I'm talking about people who are professionals in the field. But it becomes a spectrum disorder, and that's really much like other chronic conditions that we have, like diabetes, hypertension. So I want you to think about that in terms of, and maybe think about to yourself, how does that define how I've seen addiction before and how I think about it. So that's the recognition that there's a biological connection where the brain and body is involved kind of helps to contribute to that redefinition of it as a spectrum use disorder. The one key thing that, again, I want you to remember is we talk about addiction, addicts. A lot of times I think folks that don't know a lot about the subject are talking about withdrawal, and they're talking about the symptoms that people endure when they're removed from opioids, when their opioids are removed or their opioids are restricted, whether it's for incarceration or simply any other reason. The DSM-5 changed when it changed to that spectrum-based disorder. It removed withdrawal as a primary indicator, diagnostic criteria for an addictive disorder. And that is hugely important because it really normalizes, I think, addiction and the way we perceive it, because anybody, regardless of whether or not you are, quote, addicted or not, is going to have withdrawals if they stop taking a medication that they're dependent on. So I want to really make that clear. One thing that does is it takes away, I think, some stigma and the like. We see it quite often with children and neonatal abstinence syndrome, which I'm not going to get into too much today at all. But you hear a lot about addicted babies. Addiction is a diagnosis, so a baby can't be addicted, okay? A baby can be physically dependent, okay, but they can't be addicted. So again, it might seem like semantics to some folks, but real important the way we use language sometimes to define things in this field. So addiction is now being seen as a spectrum disorder and treatment more individualized. At least that's where we're going. So moving on, go through this really quickly again. This is a slide that talks about prescription opioids and heroin. Remember, I talked about the increased deaths from heroin, there's a huge increase in availability, demand, drop in price. If you can look there, you can see the overlap on that slide, and then you see the deaths from heroin kind of increasing exponentially. Prescription opioid deaths, more or less, and I'm summarizing a lot here in the interest of time, have plateaued a little bit in most places. Unfortunately, in many places, that's not the case with heroin, and that's very complicated. Reasons why. Sure, people that are cut off of their prescription opioids can switch to heroin, but it's a much more, again, it's not a linear relationship, okay? Some people are introduced first to heroin. Others choose it a little bit later. I have another slide that talks about that in a second. But essentially, the amount of seizures from the early 20-teens to the mid-20-teens doubled in terms of heroin being seized by authorities. The user population increased more rapidly than any other drug of abuse. It doubled between 2007 and 2013. I talked about that a little bit earlier. And again, you see kind of an interesting pattern where we see, and I don't have that slide here, but people are trying heroin later. There's a great study in an article by a scholar, gentleman named Cicero, and if you Google that, you should be able to find it. It's a really fascinating article about trends in heroin usage, and it turned out that he looked at this large N sample of longtime opioid users, heroin users, found that generally folks started early in the 50s and 60s, even up until the 70s. Now we've seen in the 2000s and the 2010s a later onset of heroin use, which again could have some relationship to the prescription drug crisis. So it's interesting about what our conception of users are as going forward, because I think it impacts that. Well, a lot of this is kind of throwing us on our ear, so to speak, in terms of how we perceive addiction, people who are addicted, people suffering from substance use disorders. So again, when we talk about risk factors very quickly, I think most folks know that SUD, in this case OUD, is associated with a lot of other societal factors. You know, those of you, maybe some of you are familiar with the term of socioeconomic impacts, social determinants of health. That's the term. We know that people who have, obviously summarizing a lot here, that have opportunity to get access to things like healthcare, that have things like family links, a job, a house, have a lower percentage chance of developing a severe SUD. In the treatment field itself, I know, and from having spent many years as a clinician, sometimes we talk about the drug use as being a symptom, right? And I think that's really important to recognize. Not for everyone. Some folks have developed drug and alcohol problems simply just from length of use and patterns of usage that develop psychological and physical dependence characteristics, and that's fine. But I think the question, and especially for you guys working in sometimes communities that are economically depressed, that are socioeconomically challenged, I think it's important to recognize that link and that role. You know, associations with criminal activity, prior history of stress, anxiety, you know, obviously psychological traits. Did a lot of psychometric testing in a facility for a long time, and there's definitely a correlation with that. I want to mention something really quickly, though, about females. Kind of a unique risk factor for opioid use disorder and opioid addiction. For example, much more likely to report and have chronic pain, things like fibromyalgia. Very, very interesting point in terms of, in that early, when I talked about the history of opioid use disorder, I talked about the early 19th and 20th century. Well, the majority of people, if we look back now and we said, well, who would meet a diagnostic criteria for opioid use disorder? You would have found a majority women. And even now, there's many treatment systems, many states that have treatment systems where people presenting for opioid use disorder are a majority women and being treated. So I just think that's very interesting. And I think when we talk about, it's something at the macro level, we could talk a lot more in detail about gender differences in treatment and ways to address that stuff. But again, from that big macro point of view, I just want you guys to keep that in mind. We have a unique set of risk factors and dependency. We see rates of dependency that outweigh similar usage rates in females with other drugs of abuse. So I just want you to think about that. But again, you know, anybody that takes opioids regularly is at risk of developing an addictive disorder. Again, moving forward to some current trends, again, just a summary. Unfortunately, we've had a decrease in life expectancy. It's dropped pretty significantly. Andy noted before there's a couple really simple. We didn't want to bombard folks with huge, massive lists of resources to kind of slug through, but a couple key ones. And you'll see one of those is actually just a brief citation for a study done over several years, but just published a year or two ago from Deaton and Case, some scholars, who looked at decreasing life expectancy. Bottom line, we're seeing patterns we've never seen before, especially among white middle-class males in particular, an actual decrease in life expectancy, and that is strongly correlated with opioid use disorder, overdose, liver disease, and of course death from the lower life expectancy for this group, which again is, I just think it's a really important thing to recognize, because it's really the first time we've seen that since modern medicine, let's say since the 1800s, where things like, and quite ironically enough, remember I talked about how important opioids are as a medication in acute pain and relieving acute pain. They work very well. They're fantastic. They will relieve your acute pain. They're a necessity for surgery in many cases. And I can't get over the irony a little bit of the fact that how many lives have been technically saved by opioids due to things like their use in surgery and the like. But now we're coming kind of full circle, and we're seeing the negative side of the impact, which is why I mentioned before, it's a complicated subject, okay? Huge increases in suicide along with the drug use. I think there's a lot of different connections you can make with that. But that's very clear. I think many of you have probably also seen that in the media, and unfortunately probably maybe have some experiences of your own or folks that you know, because it's touched a lot of people. We have a kind of a suicide epidemic, unfortunately, or a suicide crisis, I should say. The link between opioid dependence and Hep C cannot be understated. Huge rates of opioid users have Hep C. The vast majority, for example, in our state, in my state, in Oregon, looked and estimated that about 60 to 70% of folks who in fact have Hep C got it through injection drug usage. So again, remember, it's not pharmacology, but when I talked about opioids, and remember I talked about how quickly you develop tolerance and dependence. injecting drugs, injecting any medication, right, is a quicker way to get it into your system many times than just consuming it orally, or even in some cases smoking it in terms of what's wasted. So people begin to inject drugs sometimes pretty quickly when they develop a severe tolerance and dependence. And again, I really want to stress this is why opioids are such a complicated issue. You know, obviously the infection isn't caused by the opioid. It's caused by things like sharing needles, using dirty needles, which is something, again, that happens as people fall more and more into a more severe addictive disorder. We talked about the link also between opioid prescriptions and overdose, opioid prescriptions and how complicated is the link with heroin. We've had a significant decrease in the country overall. It's just different places, and I know folks are all over on this webinar, so I'm not going to get too granular. But we have seen a decrease. But we've seen overdose deaths increasing 38%, and that again varies area to area in the country. Dramatic mortality in certain regions, the Midwest, Appalachia, New England in particular. There's also some great work, in terms of the fact that it's good research in terms of talking about that link between economic distress and rates of opioid use disorder and drug use and alcohol use too, unfortunately. That's both. Next, I'd like to talk a little bit about the diseases of despair. Some of you may or may have not heard that term before, but it's a term that a few researchers have used that kind of talks about what are the root causes. And it's not without controversy. There are some folks that will apply different reasons that we're in this opioid crisis. One thing that you're going to find, and I think this is very relative to folks on the call if you're working with, say, community groups, medical providers, treatment providers, anyone, and we'll talk about some coalitions and examples of stuff as we go forward. It's a sort of a theme. What you're going to see is folks have different takes on why we are where we are. You'll see things like people suing drug makers. You'll see people blaming it on the physician or health systems, or people, quote, dealing drugs, or parenting or the like. I think we really have to look. You see a little Venn diagram we have there on the side. The diseases of despair model kind of goes like, if you look at especially the impact, remember I mentioned Appalachia, rural parts of New England, and urban, the Midwest. Some folks really are pretty convinced, and there's some compelling evidence to suggest that there are distinct correlations between that unfortunate triple group of lack of economic opportunity, poor working conditions, and isolation. You'll note there that quote that I used from a National Academy of Sciences reported eroded social capital, accompanied by hopelessness, despair being the root cause of misuse of opioids and other substances. Again, and then they do make mention of this quote that increased opioid prescribing clearly has played a role. But I think it's something that you want to take a look at in terms of your own work and how it impacts the folks that you serve, the folks that you work with on these issues. It's always something to keep in mind. Next one, we talk about compounding challenges. Those of you that remember a few moments ago, I mentioned, something that we talk about quite a bit in terms of challenges and dealing with this population and addressing this population, is that a lot of these people come with a host of other problems and other difficulties that just go far, far beyond their actual drug use itself. Some of those compounding challenges involve a lack of housing, vocational support, the role of stigma and discrimination as it applies to how people with addiction and addictive disorders are seen, access to services, lack of treatment options, and there's some other interesting things too. Talk about older adults. It's oftentimes a population that we kind of forget about when we talk about this. There's huge rates of hospitalization as a result of opioid use disorder and other related things in this population, and it's something that's oftentimes kind of neglected. Also, the role of PTSD and trauma. Some studies have suggested that up to 30-odd percentage of the population in the opioid treatment program actually meet diagnostic criteria for OUD. So all of these challenges work towards issues that we need to address when we talk about this population. So again, moving forward to our next slide. We'll take a quick break and ask a question. What type of social and economic challenges do you see in your community that could compound opioid use? And Andy, I don't know if you want to help facilitate some discussion for a moment, or?
Sure. Thanks, John. So the question is there on your slide, and we want to hear from you now. So to do this, please use the chat panel, which you should see on the right side of your screen. If you don't, look towards the bottom of the slide. Click on the small circle with the chat, the speech bubble icon, and that will open up the chat for you. We want to hear your thoughts on this question. What kind of social and economic challenges do you see in your community that you think could compound opioid use? So we've got a bunch of your ideas coming in already. Seen several with social isolation, thoughts around that, disconnection, lack of job opportunities, unemployment, lack of access to resources, lack of available treatment. So a number of things related to services and treatment not being available. Yeah, lots and lots of things here about unemployment, lack of jobs, employers moving out, and all of the things that leads to, that the economic depletion of resources, homelessness that then can result. Wow, you guys are great. I can't keep up with all of these, with all the ideas pouring in here.
Yeah, it's true, Andy. I think it goes to just how kind of complex the issue is, and how many people that really impacts. I did notice before we go forward that I think somebody mentioned Native American communities. There were a ton of stuff that came through. It's great the participation. Someone just mentioned mental illness. You have disparities. You know, I mentioned that the impact, decreased life expectancy on middle-class white Americans, but also, you know, it's been made bigger subject than we have time to get into, but a lot has been made about that in the media, and a lot of it's true. It really has impacted. One thing to remember, though, is that in the Native population, I mentioned those of you that work in that space, and in tribal communities or other venues, they've increased, their death rates increased 3 times over the last 15 to 16 years than other groups. So again, they're disproportionately impacted, but again, I think you see that Venn diagram, unfortunately, of poverty, isolation, especially in rural areas, lack of economic opportunity. So I certainly don't want anybody to get the impression that this is just disproportionately impacted one group. It's such a complicated issue that it's affected different groups in different ways. In many cases, you see the African American population, you see in urban areas higher death rates among that population than you do among the white population or others. So again, it's important, I think, to dive sort of beyond the headlines and look at how it impacts sort of different populations or different places where you're at in particular. Let's move forward to some models that we talk about. So it's not all bad news, right? So I don't mean to depress anybody too much. But again, what are the models when we talk about how do we address this? Because we talk about what's been the impact, what are the problems caused? And this is a very brief sketch here of primary and secondary interventions and tertiary interventions. So what's primary? I think we can all say that. Things like stopping drug misuse or abuse before it stops, before it starts, of course. You know, there's lots of different things. There's tons of education and evidence-based models. Advertising use, you guys might work in communities or work with programs that have done some, maybe advertising. We've had different, out here and in many communities, you've had different advertising things that talk about the impact of drug use and what that has been on communities. I want to have a word of caution to people. Remember, I talked about what are compounding issues when we talk about stigma and discrimination. We want to make sure that if we're doing things like public information, that we make sure that it's done in a way that doesn't help perpetuate stigma and discrimination. So I think that's real important, or focusing on the person as the problem instead of the issue. When we talk about what's secondary intervention, right? Well, that's treatment in many ways. A couple different ways that we treat folks with OUD. We talk about medication-assisted treatment, not the sole focus of this, but an enormous issue that I spend a lot of my time on, and also a key evidence base with 50 to 60 years of evidence supporting it to help to mitigate the opioid crisis and related outcomes from that. MAT is clearly effective. World Health Organization, even back in the 2000s, and this is, again, one of those really consistent numbers, calculated return $12 for every dollar spent. We find that folks that are in treatment that don't have an opportunity to engage medication-assisted treatment generally have 80 to 100% relapse rates when maintenance is discontinued, when medication-assisted treatment is discontinued. Detoxification, again, is a kind of a hot-button issue when we talk about treatment. And remember, I'm on the secondary section here. And I want to just also use this as kind of a backdrop to talk about a few programs as we wrap up. And so think about this slide as we go through those and how it kind of relates to some of the things that we talk about, just so you can get an idea of models. We treat opioid use disorder folks with medication-assisted treatment generally in two forms. We can use agonist or partial agonist medications or antagonist medications, right? Remember when I talked about a little bit about the pharmacology and how opioids work in the brain? Well, your agonist and your partial agonist bind to that MU receptor, right? Again, we call this substitution therapy. It's replacement therapy. Remember I mentioned how that external opioid that you're taking in almost takes over the job of your emotional regulation, of your endogenous system. Well, what these drugs do, and one reason why they're quite unique with something like methadone is that it's a long-acting medication. So what I mean by that is it slowly, surely, and steadily provides that little bit of euphoria and analgesia that, and this is exactly why, and this is important, why we do MAT, it's to relieve withdrawals and cravings. Okay, that's it. It's not a replacement for other psychosocial interventions. It's not a replacement for getting someone home. It's not a replacement for talking through issues involving trauma. It's not a replacement for culturally specific treatment. It's simply a medical adjunct that has been proven to work and has, again, decades of experience, decades of empirical evidence suggesting its effectiveness. So, tertiary, the last, something that, again, is not without controversy, is really harm reduction, right? We're talking about reducing morbidity and mortality. We're talking about getting people, making sure people are safe or trying to make them safe. And that can involve giving them drug testing strips so that they can test what their drugs are being used. Those actually are also used in police departments as well, and law enforcement. I shouldn't say the word police department, but just law enforcement in general. Again, when I said not without controversy, things like safe injection sites, which is a huge point of controversy in many places, but has been shown evidence-wise to reduce infectious disease. I want to also make a point, and it's not an endorsement, but what's very important, especially when we talk about when we talk about trying to address and mitigate the factors of OUD and the consequences, we want to make sure that, where's the place where we need to start? Well, where these folks are, and in many cases the people are, because opioids are so highly dependence and tolerance inducing, people continue to use these drugs until there's an option or until treatment is available. We also have naloxone, which again, won't talk about too much. Many of you guys have probably heard of that. It's the overdose reversal drug. It's also known by a trade name. Naloxone's the generic name. You might have heard the words Narcan. There's other different versions of it. And that works a little bit differently. It's an opioid antagonist. But I always use the analogy, let's say that there's your little MU receptors in your brain that are taking in the opioids. Naltrexone kind of kicks them off, right, because it's an antagonist. If you're opioid naive, you don't have any opioids floating around in there, it will cover your MU receptors and block any opioids coming in. But if you've already got opioids on there, it'll kick them off. Hence, that's why it's used as an overdose reversal drug. It almost, and you'll be interested when you see the title of the next slide and the project that I'm going to talk about real briefly. It's kind of a miracle drug in a sense, in terms of it can take somebody directly out of an overdose state. Remember, as opioids build up in your brain, you get that more and more euphoria and analgesia. Well, overdose is respiratory depression leading to death. When you kick those opioids off, that chain, the naloxone, so to speak, puts a wall in the middle of that chain of that process, and it reverses it. So what a marvel of modern pharmacology. So again, moving on to different project spotlights, and I said kind of a miracle. You see, I want to focus on a couple things that work. We've talked quite a bit about what the problems are around use and misuse. But I want to focus on a couple different projects that are really great work. And for you guys, in terms of your role as VISTA, and just something to kind of think about in terms of what types of projects are you involved in around the opioid crisis. What are some different ways to think about it? I know people are in different roles and the like. Well, let me just jump in, and you'll have these slides, obviously, to refer back to if you need to. Project Lazarus, which is in Wilkes County, North Carolina. And this kind of focus, I tried to pull a few out to focus on my list of 3 different areas. But again, as I look back, they touch on a lot of things when I talked about primary, secondary, and tertiary. This kind of does a lot of all that. You know, in 2009, the overdose rate, as you see, was 4.5 to 5 times the state as a whole. So what did they focus on? Treatment and recovery resources, harm reduction through naloxone to reduce the death, resources for patients and families. Remember, I talked about the social aspects of opioid use disorder and just addiction in general, training and technical assistance, guidance toolkits, even in-person training and medical education for prescribers. So if we go forward into the results, you can see that significant work was done. Significant successes were noted. Obviously, overdose-related deaths were reduced from that harm reduction model. Drastic increase. We talked about that role. It's a complicated, I keep going back to that Venn diagram. So it's not just one area, I think. You know, we can reduce death. You know, we can try to reduce overdose. I've used the analogy with folks and my colleagues and others when I've talked about it, is it's a little bit like when you squeeze a balloon, right? You can grab one of those thin balloons, you can squeeze it, and you'll restrict it there, but in another section it will pop out. And I think that's a great analogy to use when thinking of opioids. So I want you to think big picture, basically. Again, engage prescribing physicians in using more pain agreements and prescription monitoring programs available. Those states have them available now. But again, some hard numbers, unintentional OD dropped significantly. You see that 69% in just a couple of years, right? And I want you guys to think about that. This is just really from using a very basic training and awareness model, getting folks together, making them aware of the problem, reducing stigma by saying, hey, you know, please, if you have a family member, you have a friend that has a problem with opioids, I want you to have some naloxone. Very positive, non-judgmental type interventions, but you have that very tangible thing, 26% reduction in emergency room visits. So significant outcome for sure. So next I want to focus very quickly on Project Vision in Rutland, Vermont. Vermont has had one of the highest rates of illicit drug use in the U.S. Certain parts of that city were particularly kind of impoverished. Remember I talked about the links before. And in 2014, they had a gigantic spike in drug-related arrests. You're going to see, obviously, and I don't think it's a shock to anybody, that we talked about the criminalization of addiction. We talked about how people are perceived and law and the rule. So this huge spike in drug-related arrests happened. So really, instead of focusing on, okay, let's make sure that we get people super and super sentenced, what they did was they came up with something called the DMIM, or Drug Market Intervention Model, where they took folks who were arrested for possession. Of course, this is not talking about high-level traffickers or distributors, and formed a group, right? Trusted community members, police, and they also engaged in community improvement tasks, help the neighborhood in general. But it was really, I really showed this as an example of law enforcement supporting treatment, and that's something to think about when you work in your various communities and areas around this work, that a lot of people can be partners. You know, it's not just people in direct social services. So in terms of the results of this project vision, there were lots of different things: an increase in owner-occupied homes in the area. Recidivism was reduced tremendously by folks who did go into those, what they call them, reentry panels, and part of that drug market intervention model. Massive reduction in burglaries, you see that, over 56%. But again, I want you to, you know, and the disposable medication, which is fantastic, but in terms of actual programming, I want you to note that the substance abuse counselor in the probation and parole offices, a huge, huge thing. So that's really, there's another, again, I want people to look at partners as they go forward and not be narrow focused. We've talked about how broadly, I think one of the things I tried to do in this presentation is focus on how broadly the opioid crisis impacts different people in different roles. And that's a great example of it because law enforcement sees it too. So again, we go on to the next project. As we go on to the next project, I wanted to briefly highlight State of Rhode Island. I understand this is not purely a medication-assisted treatment presentation, but one thing that might be of note is it's very hard to get medication-assisted treatment in correctional settings. It's tremendously difficult. There's only a couple states. Rhode Island's one, Connecticut's another. Even county jail systems, one's in Albuquerque, New York City's Rikers Island system also has an opioid treatment program in it where they put people on methadone, they maintain people on methadone. But again, it's just not a huge, widely used thing. It's becoming more noted what the impact is. And this is just an example of that. So Rhode Island, you know, one of the highest overdose rates in the country. What they found was that a couple of years ago that about 15% of all the overdose deaths were actually people who had just been released, or recently, I think within a year, from incarceration. So that's huge, right? You've got a relatively small, incarcerated a lot of people in this country, but still a relatively small percentage of people compared to the overall population. But when you think they attributed, or they consisted of 15% of all the overdose deaths. So they got very proactive and they offered a full scope of medication-assisted treatment. You can see the results. Statewide overdose deaths were 179 in the first 6 months of 16 and went down to 117 in the same period in 2017. But one thing I think that's really interesting here, and I jumped to that second to last point, but also the first point that I made, when I say large increase in synthetic opioid prevalence, this is the time where a massive amount of fentanyl was becoming available on the streets. So even with that, what I'm saying is these projects can work, right? Projects can have very tangible impact that you can sometimes see immediately. 61% decrease in the overdose death for released inmates, and they estimate 1 prevented for every 11 inmates treated. So you've got a situation where you're dropping overdose rates as a whole, while availability of things like synthetic opioids have gone up, in fact. So I think that's important to note. So again, just a couple things for guidance moving forward, and then I think we'll start to move into a more formal question and answer session that Andy and I will help moderate. When I say guidance moving forward in this slide, talk about what are some things to think about as we talk about when you are starting to think about these projects, how you can participate, how you can get others to. Look at established models. That's why I showed some examples. I have that little quote there, don't reinvent the wheel. I can't stress that enough. I've done it plenty of times in my life with different things. But it's just something to keep reminding yourself. If you think about something, there might be somebody who's done something similar, so put that effort into to looking at that and other models. Also research links, because you want to be able to show what you're doing, how you're doing it. Could be for anything from publication to just improving your own. It could be external, I should say, or internal. So It could be for presentation, publication. It could be to model to another program. It could simply be for quality improvement within your own program. And focus on small successes. I mentioned that when I talked about those projects, you know, you had, when you initiated harm reduction activities, you had an impact, okay? But when you began to give MAT to prisoners, you had an impact, okay? So don't look for, I always say to folks, we're mitigating this, we're not solving it. Remember I mentioned 5,000 years ago, there were some folks in Mesopotamia, modern-day Iraq, that were using opioids. So don't try to get too caught up in solving. We're mitigating and we're helping improve people's quality of life. Your volunteers, make sure they have ownership of the program. A lot of people working in communities. I talked about some hallmarks, especially when we're talking about isolated, impoverished, sometimes disenfranchised communities. Rely on the people that live there. You know, those are the people that I think that you're going to need in a multitude of ways. But those are the people that when you make relationships with, they're going to be able to drive your work. It's going to be authentic and it's going to mean something. And collaborate, of course. I don't think I need to overemphasize that, but that's kind of a part of what I talked about. You know, ownership, collaboration, trying not to reinvent the wheel, and giving folks ownership of their work. So, well, you know, again, we've covered quite a bit today, and I think we're going to move right now to a chat question, which is, what ways does this topic intersect with the work your organization is doing? You know, I know that we've heard a lot about a lot of treatment options and projects and approaches in different programming and history and the like, but I want to kind of pause now and then maybe turn over to Andy to moderate some questions if folks have one. I see stuff popping up here and there.
Sure. Thanks, John. And again, we'll use the chat panel on the right side of the screen. So if you've heard or seen something so far in the presentation that resonates with you and you think could be applied in the work that you're doing or somehow might intersect with what you're doing as a VISTA member, please share those thoughts using the chat. All right, so we're starting to see some come in. Earlier I saw one of you mentioned that you're actually using the Lazarus Project model at your site, so it was nice to see that connection here. Let's see.
Oh, that's great.
Karen's working, serving at Sonoran Prevention Works, whose mission is to maintain dignity and to reduce stigma for people with, I guess that's with use disorders, through many tertiary prevention strategies that you talked about, John, so great.
Good. I don't think that we can understate the value of that. You know, a lot of people don't. We've got a ton of ways to go to develop a better treatment system programming, to integrate things more, but I think overall we really can't underestimate the power, unfortunately, that stigma and discrimination have. You know, and I think you can take addiction out and you can exchange it with a lot of other things. You know, a lot of things that prevent people from coming forward, especially with severe problems, is that shame and guilt that comes with the stigma.
Yeah,
and fear of being rejected.
Yeah, sorry. Here's an interesting concept. So Aaron is with a literacy program, and they're actually going to the treatment center in their county to recruit students for literacy. So I'm guessing the notion there is to support people with training and learning to build their job readiness, give them skills so that their chances of employment go up and perhaps chances of recidivism or relapse go down.
That's great.
Here's one providing legal services to people who are in recovery, usually medically assisted treatment. Here's a Train the Trainer project working across the state with a variety of organizations. Someone's working to expand medically assisted treatment services in their community, educating the public.
Yeah, I noticed, I'm just trying to look, there's something about housing. Somebody mentioned something about housing. I don't know if we're looking at the exact same thing, Andy, but that's good. I wanted to make that note, not to go back to the bad news part, but it's one very unfortunate thing is that it's sometimes very difficult for people on MAT because of the stigma against it to get into housing. A lot of folks don't consider it to be, quote, real recovery because it's not the classical abstinence model. These are big concepts, I know, and we don't have necessarily time enough to dive into all of them today, but there are things to think about when we talk to people and interact with people, both people being served as well as the system, people working in the systems.
Yeah, and a couple of participants here mentioned that they are working to collaborate with other organizations, so seeing what everyone else is doing, maybe creating a directory or helping people in need to access those services across a range of organizations. So your point about collaboration, John, is right on. All right, so we realize you probably have other ideas to come in here. So feel free to keep telling us a little bit about what you're doing in your VISTA service, and we've got a couple more slides, and then we'll get to your Q&A. So, John, I think you're up with resources.
Sure, and just very quickly, I'll talk about these resources here. I didn't want to overload folks with a million different resources, but here's some keys I thought about from keeping with our theme. You've obviously got the SAMHSA website. I see some of you are involved to some degree in treatment projects. This might not be new to you. If you look at that, and for those of you that don't know SAMHSA, it's a Substance Abuse and Mental Health Services Agency, which is a division of the U.S. Department of Health and Human Services. Really what they do is lead public health efforts to advance behavioral health in the nation, essentially. And their mission statement is to reduce the impact of SUD and mental illness on America's communities. So again, a great resource. I'd direct you if you want to. SAMHSA's got a lot of different resources. You can go to resources for communities and families. And there's so much stuff on there, and I'll let you guys dive into it on your own time. But I'd encourage you to look. Remember, I had those three kind of buckets that we talked about, tertiary, secondary, and primary. You'll find things on all of those, and you'll find very tangible things as well, both for providers, communities, and families. And remember, this is your government at work. So they have material for you to use, which is public, can be used by anyone for educational purposes. So I want to make sure that people are aware of that. Legal Action Center, another great resource. Related to our topic, they have an addiction and substance use project that promotes prevention and treatment, combats discrimination, et cetera. Great stuff on there. Also, if you look at that note that I put for case and Deaton, mortality and morbidity in the 21st century, that was a report published in March of 2017. So, and I think it might be available at brookings.edu. And it's available in a bunch of other places, too. It's kind of a Googleable thing. Those are different resources. And there's tons more. I'm just popping my head into the little chat box here. And before I move on to what you're seeing now, opioid-focused VISTA projects. Somebody mentioned, I think I made a brief mention of Native Americans and the impact and resources. Someone mentioned that. I encourage you guys to do things like this. So there's other groups. And you'll see, SAMHSA made me think of this because you'll see, if you go to the SAMHSA site, and I'm speaking especially that population I mentioned, there'll be subsets on the SAMHSA site where you can dive into more information on those things. Also, the Indian Health Service is a fantastic resource as well. But anyway, before we'll do more Q&A, opioid-focused VISTA projects, I just threw out a couple simple ones here. These are examples. And I don't know, I'll mention them real quick, Andy, and if you want to jump in and say anything that you guys know about that. I also think we might have people on there that are involved in them. So.
Yeah, and we've already seen with that last chat activity a number of you who are working specifically with opioid-focused VISTA projects, and others of you are serving on projects that aren't specifically focused with opioid work, but there's a natural intersection there that we've already discussed. But here are just a few, and there are many, many projects out there, so these are just really just the tip of the proverbial iceberg of VISTA projects that are working specifically in opioid programming in a variety of different ways. Some of these have not been in they haven't been operating all that long, so they're still sort of in a startup phase. So it's a little bit early to have any actual outcomes or results. But you can see here in some of these different regions where VISTA projects are working in a number of different ways, and it sort of mirrors what we saw in that earlier chat activity. So we'll leave it there, and we're certainly interested to hear more from all of you. So let's go ahead, and as we move towards our Q&A period, I first want to let you know that we do care what you think about our webinars. My colleagues and I put these webinars together, and so we really do appreciate your feedback and input on what you find useful about this particular presentation, but then also topics that you might like to hear about. So you can see on the right, Joanne has opened up our evaluation poll. 10 simple questions. Use the slide bar all the way on the right to scroll down so you get to all 10 questions. Be sure to click the submit button so your answers get registered. We do take a look at all of those comments, so please take a moment if you would to do that. And then we're going to move into the Q&A. And you've probably noticed that when we opened the poll, the Q&A panel has collapsed. You should see the word Q&A just above the poll. You can click the little caret or the little triangle next to the Q&A, and it'll reopen so you can submit your questions that way. And I'm going to invite our operator, Brandy, to come back on the line to give us instructions for those of you on the phone who want to ask your question that way. So, Brittany?
And as a reminder, if you would like to ask a question, please press star, then 1, and record your name clearly when prompted. One moment as we wait for the first question.
All right, so while we're waiting, we've got several questions that have already come in through the Q&A. So John, first up, Adrian says, is NAS a valid reason to advocate for total detox instead of medically assisted treatment for pregnant mothers? So a little bit of jargon there, and I'm sure you're more aware than I of the implications there.
No, that's a fantastic question. And it's one of those things, unfortunately, that it's just time-wise, it's hard to take too deep of a dive into some of this stuff. But the answer is no. Maintaining moms who are expecting on methadone and medication-assisted treatment is really the gold standard, and I'll tell you why. It's a lot of this for stress on the fetus. But again, remember I talked about those other factors that go along with especially when we're talking about IV drug use. IV drug use, in many cases, comes along with a lifestyle that I don't think this is earth-shattering to anybody. That's not super conducive for good prenatal care. Criminality, illicit drug use, transactions, infectious disease. The bottom line is that there's an overwhelming amount of evidence to simply suggest that, keeping and maintaining folks on that is really has a much greater, higher outcome of success for mother and child as well. One thing of note before I move on too is that a ton of work done on NAS because the prevalences are really quite outstanding right now, just numbers-wise. So we had a study that was done actually from a researcher not far from us who was the principal researcher investigator who looked at what was the biggest factor involved in the severity of NAS among children as they were born to moms that were opioid dependent. And as they sorted through, it wasn't the methadone, it wasn't, obviously that's the source of the NAS, but the largest correlation between severity of symptomology was in fact smoking or not. And that was much more strongly related to, so I wish it was an easy answer, but it's complicated. But the bottom line is no. Medication-assisted treatment is the medically accepted gold standard for treatment of pregnant women. who have opioid use disorder, of course.
Great. All right, thank you. Next up is a question from Isabel. Has there been a concurrent increase in rates of depression and opioid use in the white middle class, or is it just an increase in mortality? And does the increase in overdose have to do with increased use of fentanyl?
That's a great question, and there's no doubt about the fact that that's driven some of the mortality increase, synthetics. Again, keep going back to that theme. We didn't really have as much time. It's just there's only so many things we can talk about. But fentanyl is an incredibly powerful opioid, synthetic opioid that's not particularly difficult, unfortunately, to manufacture. So purely synthetic. We use something when we measure opioid strength called MEDs, which is morphine equivalent doses. Good way to say this is we kind of have a bar, a baseline, like 1 milligram of, say, morphine. You know, how does that compare to the strength of the other opioids? Well, think of fentanyl as being approximately 50 times, in many cases, stronger, but there's all kinds of variations. So, yeah, fentanyl flooded the market. That increases mortality. But also, yes, there has been a rise, a concurrent rise in terms of mental health conditions such as depression, anxiety. But again, I'd also note that you don't really have two chronic conditions that have so much overlap. I mean, I think there is with some things like diabetes and hypertension in many cases, but, you know, when you look at that overlap between SUD and mental illness, it hasn't always has been there. That's where you get back into those compounding factors I talked about and socioeconomic factors where, again, those of you that know some about sociology think about protective factors. Well, these are kind of harmful factors, and I think it's important to note that it's not just the drug, right? The drug sometimes becomes a way to cope with that. And when you talk about isolation, economic challenges, everything from lack of an education, you know, these are things that are pretty consistent as being negative and will help exacerbate what's unfortunately a bad situation to begin with. So, yeah, there's definitely a correlation.
All right, great. Let's see, Aiko asks, are you aware of specific resources for ESL or limited English proficient speakers? Apparently they are a multilingual service center.
Right, and that's a fantastic question, and it's one, again, it gets back to kind of mentioned before about, you've seen a lot of stuff in the news about places like Appalachia and impact on like a white rural population. Got to remember, it does impact a lot of folks in a lot of different ways. SAMHSA will have some basic language materials in actually a multitude of languages, talking about addiction and opioid use disorder in terms of public, public information type materials. And they publish in a bunch of different languages, not just talking about Spanish but I'm talking about Southeastern Asian languages or Russian, different things, and depending on the community and where you're at and what area of the United States you're in. I would have a suggestion, though. A lot of, especially if it's around opioid awareness and even angling into opioid treatment, a lot of states in a lot of regions will have different organizations that are culturally specific and culturally focused. For instance, we have a relatively, compared to the system as a whole, small but very, very active and passionate and knowledgeable group of providers that work in the Latino communities in Oregon, and they have regular meetings, and when you get back to cooperation and collaboration, I'd encourage you to reach out. You know, I'm just using that one example, but yeah, I'd encourage you to reach out to those groups and talk about what you're doing, because you'd be surprised. You wouldn't be surprised, but I think that's a bad way to put it. But I think you'd be heartened actually by the fact that sometimes folks want to be reached out to and become aware of their work. Remember, I talked about opioid use disorder as being a very multifaceted and complicated. And there's sometimes where, and I find it in my work, people are doing things that are positive and that are great, but they're not aligned with other stuff others are doing. So it's really just a matter of connecting and saying, hey, let's get together and talk about what you're doing in this space, what I'm doing, and then see how it impacts going forward. So.
All right. Let's turn to the phones and see if we have any callers who have questions.
No questions on the phone.
All right, and as a reminder, if you did dial in and you want to ask a question, please dial *1. Be sure to unmute your phone and record your name. We've got a few other questions queued up here. So Miranda says, I work in a MAT clinic, again, medically assisted treatment clinic in Tucson. Something we've seen is a lot of antibiotic-resistant infections. Have you seen any data on this, or are there any educational materials available for clients or patients? They are looking to provide more educational materials. So John, any thoughts on resources or information about antibiotic-resistant infections?
Well, on the medical side, well, first of all, let me say I mentioned infectious disease briefly. Tremendously huge issue that we're seeing right now. It's a huge healthcare cost driver. We see it in our state. I've seen data just showing this increase. Coincidentally, what happens a lot of times is people present at a hospital, in this case. Sometimes, remember, I keep going back to those themes of opioid use disorder when it's on the severe end of that spectrum I talked about. It can kind of be all-consuming. And for those not particularly familiar with addiction or addictive disorders, especially of that gravity, just put it bluntly, a lot of stuff goes by the wayside. And healthcare is one thing. Infectious disease is incredibly common. It's on a rapid rise. A lot of times, for instance, what we've seen in some local hospitals here are cases of endocarditis, organ infections that really need a course of antibiotics that's 6 to 8 weeks long. So you get folks that are heavy IV drug users and they're constantly getting these infections. I guess I try to end on a successful note, but on a little bit of a bleaker note, we're kind of seeing this pattern where people are being treated with so many antibiotics to rightfully so kill these infectious diseases that they have in their bodies. But their bodies are obviously becoming tolerant of that. So it's a huge issue. There are some resources, and I can probably get those to the VISTA team or, and just a couple informational things. I don't know if you really want statistics or educational information. SAMHSA has some of that, but, that's certainly something maybe could be made available at some point. But just as an overall point, it's hugely prevalent, and it's a huge healthcare cost driver. That also is contributing to mortality as well.
All right, thank you for that. And let's see, Sakar asks, what kind of education do you provide to someone who might be an opioid abuser or has this, use disorder, to let them know that there might be a better way to live other than using the opioids? So, general thoughts about the educational approach?
I think, again, it really focuses on the group. Think about it in our 3 model slide that I showed. Prevention, we talked about community connections, especially with the younger population, identifying harms and hazards of drug use. That might be more of an effective thing with that group. But again, doing it in a way where we're not increasing stigma and discrimination towards people that are already involved in, unfortunately, opioid use and misuse and all the consequences associated with that. That's kind of one group. You also have pain patients that are a huge concern. Many folks are going to be on long-term opioids for a variety of different things. And an approach with them is really, again, back to that, focusing on safety, focusing on quality of life, focusing on the patient and whether or not opioids are really, truly helping them. And maybe not necessarily removing or taking away, quote, taking away someone's medications, but looking to kind of manage them better because it was a part of the crisis in driving it. And also when you're talking about that population of severe use disorder folks, you're really encouraging the providers you work with to embrace MAT, to use it, to make it available to folks, lowering the stigma and discrimination about that, which unfortunately can exist in the recovery community itself. And also things like making the lock zone available and harm reduction in a non-judgmental way that's going to engage people, because then it's going to reduce the societal harms of that. We talked about OUD as a spectrum disorder, and what's really needed is continuum of care, and you guys working on special projects have a huge role to play in that. because you can really fill a gap in between your kind of classic the three boxes that I noted, in between the prevention, families and children type early prevention, and then the actual delivery of treatment services, and then the tertiary harm reduction services. I think you guys can really play a role in helping to develop systems that work around that. But it's not easy. We see a huge. Remember, I mentioned on one of the slides about relapse rates in the 80 to 100% range. What that really is are folks that are either forced, and that happens unfortunately, forced to titrate off their medication, never offered them in the beginning. We just have a really unique thing. Remember, I talked about when methadone treatment started in the 50s and 60s in New York City. That's really how it started, because people said, gosh, why don't these folks ever get better? And they thought, gosh, now we're going into this is a brain condition. This can't be simply an issue of willpower. So I think it really depends on the group that you're working with. And I want to stress, remember, we're talking about mitigating a problem and mitigating what the societal impact is, not necessarily solving everything tomorrow. It took us a long way to get here, so it's going to be a long journey going forward.
All right, and in a couple minutes we have left, Adrian is curious, how can we have accurate information about opioid-related deaths when there isn't a mandatory standard for a coroner's office to report it? So it sounds like Adrian's got some detailed inside knowledge about it, but John, do you know where the opioid-related death information comes from, how that's gathered?
Well, Adrian, you hit the nail on the head. That is a tremendous problem. We have, in our state, we have a pretty good system where the medical examiner is very, very involved, and the toxicology and the levels, and that goes into determining the cause of death. That, unfortunately, is not the case in many places. I've seen reports from various states where somebody will die of a drug overdose. That's very clear with drugs present, drug paraphernalia present, high levels of drugs in that person's system, and it will simply be listed as cause of death as drugs. So it tremendously varies state to state. I'd encourage people that are working in that space, when they're talking about, let's use an example of, we're talking about system building, we're talking about trying to address a problem in a community, is really identifying who the key people are in that and making sure that they're aware. Remember, all this is happening very quickly. There are people that work in law enforcement that don't know much about the social service side. There are people that are working in treatment that don't know much about the other side. So I think you guys, again, as I mentioned before, are in a unique place to kind of bring folks together. But the bottom line is, you're exactly right. It's a tremendous burden in terms of finding out statistics. One thing that I would note for prevalence rates, and I know it's not the actual death rate, the National Survey on Drug Use and Health, and NSDUH does a fantastic job of that, and they break it down by, and all that stuff's available on the SAMHSA website as well, in tabulated data state by state. So you might want to look at that for prevalence. And of course, the issue of calculating drug-related deaths is just something we're going to have to continue to work on. I agree, a national standard would be great. You also have different resources that folks have available, so that might be something to advocate for in the future.
All right. Well, John, thank you so much for all of this information. There's a tremendous amount that you've shared, and I know you've got a wealth of other material that we could have gone into had we had more time, but we are at the end of our time together. I want to thank everybody who attended today and everyone who participated in all of the activities and the Q&A session. We will be following up with by posting a recording of the session on the Vista campus, along with a copy of the slides and that list of additional resources that John mentioned. So check back to the webinars page of the Vista campus to look for that. We'll also send out an email to you all so that you'll know when that gets posted. And we invite you to come back for future webinars, and you can see the link there. They're listed on the Vista campus on the Webinars for Vistas page. Thanks again for all of your support. From Education Northwest, I want to thank especially our producers for today's session, Bethany DeSablin and Joanne Lau, consummate professionals who make these sessions work so smoothly. Thank you for all of your support. That's it. Thank you all, and thank you for your service.